In case you have not heard already, the date and location of our next National HHT Patient and Physician Conference has also been announced. It will take place just outside Philadelphia on April 6th through the 7th, and registration details will be provided in the coming weeks. But please do save that date. There really is no better way to ensure you're up to date on the latest in HHT research, treatment, and care than by attending one of our conferences. Next, we are excited to share that our 15th HHT International Scientific Conference will be held at the Pullman Mandalou Bay and Mandalou La Napoule, France on October 15th through the 19th, 2024. This conference is one of the more meaningful ways we advance treatment and care within HHT. It fuels innovation and sparks collaboration amongst the world's leading physicians, researchers, and scientists. Next, I have a bit of an ask for the community, which is participating in research is one of the most meaningful ways you can contribute to a brighter future for our disease and all of its patients. We have several important research projects underway, and you can learn more about things like the Brain Vascular Malformation Consortium, tissue donation, or our newest clinical trial, pazopanib, by visiting the research section of our website. Finally, before we officially get underway, I wanted to go over some housekeeping rules for the webinar to make this event as interactive as possible. If you have a question tonight for one of our presenters, please type it into the Q&A box to the right of your screen. We recommend that you keep your questions general in nature so they benefit everyone. I will ask as many questions as time allows. I will also be posting resources relevant to tonight's topic in the chat box. You can use the chat box tonight to make comments to either an individual or all participants on this webinar. But please remember, do not post questions for the presenters in the chat box. Those questions should be typed into the Q&A box and field. This presentation is also being recorded. The recording will be saved on our Cure HHT website and posted in our resource library. And at the end of the discussion, you will be emailed a brief survey. Your input is critical for the development of future webinars, so please do take a few minutes to give us your feedback and fill that out. And with that, let's get going. It is my pleasure to introduce tonight's speakers. We are joined tonight by Dr. Hammill, who is a pediatric hematologist-oncologist who has been caring for people with vascular anomalies for 14 years. She is the founding director of the HHT Center of Excellence at Cincinnati Children's. She is very interested in educating others about HHT, particularly its presentation in children, and in finding new targeted therapies to improve the quality of life and prevent frequent complications. Also with us tonight is Dr. Whitehead, an associate professor of cardiovascular medicine at the University of Utah. Dr. Whitehead is also the co-director of the Utah HHT Center, and in this role provides overall medical management and coordination of HHT care to patients seen at the university. At the end of our presentation tonight, we will hold a 20-minute moderated Q&A session, so please do take advantage of this opportunity and get your questions answered by our experts here tonight. And with that, Dr. Hammill, I'll turn my screen off and turn the keys over to you.
Okay. All right. Hello and good evening. I'm really excited to be here with Cure HHT and all of you to talk about one of my favorite things, which is pediatric HHT. I have a slide for my disclosures. None of them are directly relevant to what I'll be talking about tonight, but I hope that they might be soon. Today, I really wanted to go over the clinical criteria for HHT and emphasize the ways that these are different for kids. And because of these differences, talk about how important genetic testing is for children, even more so than in adults. This is important because we need to know who needs to have their screening and who can be ruled out and not have to go through the serial imaging. And then finally, we'll review the current pediatric guidelines for that screening. So as you all know, HHT can be diagnosed clinically using the Kurosawa criteria. There are 4 criteria, and the presence of 3 or more gives a diagnosis of definite HHT, while 2 is suspected, and fewer than 2 is considered unlikely to be HHT in an adult. We'll step through these briefly one by one. First, epistaxis. To meet this criterion, nosebleeds have to be spontaneous and recurrent. 95% of people with HHT will ultimately develop recurrent nosebleeds, but it is age dependent with an average age of onset of 12 years, so it might not be present in children. And while there are no universally accepted numbers, we use more than 4 nosebleeds per year as our cutoff to meet this criterion. And this is supported by recent work from the Utah group, including Jamie McDonald and Dr. Whitehead. Moving on to telangiectasias. These are small red or pink spots that blanch with pressure and rapidly refill upon release, suggesting that they're actually these tiny high flow lesions. In HHT, there are usually multiple discrete spots, most classically on the lips, tongue, and palmar fingertips. The appearance of these is also age dependent, with less than a third of people who have HHT showing telangiectasias by age 20, but 2/3 showing them by age 40. We used to use 4 as our cutoff, but that recent paper that I mentioned out of Utah suggested that even 2 in the most classic places is enough to meet this criterion. Moving on to visceral involvement. These include AVMs in the lung, brain, and liver. And as you probably know, AVMs in the lung can show fatigue, shortness of breath, decreased oxygen, asthma-like symptoms that are poorly responsive to beta agonists, migraine headaches, or sometimes these dramatic and life-threatening presentations caused by paradoxical embolization, causing TIA, stroke, or cerebral abscess, or rarely even pulmonary hemorrhage. Brain vascular malformations are often asymptomatic, but they can present with symptoms including seizure, headache, or in the case of rupture, a hemorrhagic stroke. And finally, liver AVMs are quite common in HHT, but only cause symptoms in a subset of those and almost exclusively in adults. So I'm going to defer this discussion to Dr. Whitehead. And finally, the 4th criterion, which you all know too well, is family history. HHT shows autosomal dominant inheritance because a single abnormal copy of one of the genes involved is sufficient to cause disease. This is usually, but not always, inherited from a parent. More recently, we've learned that there are other ways to have HHT, including de novo cases where a mutation happens in a germ cell, the egg or sperm, or very early after fertilization. Or in some cases, it can even first show up as mosaic, which means that this mutation is not present in all of the cells in that individual. And the difficulty is that then it may not be picked up on blood testing or even saliva or cheek swab. So looking at these 4 criteria here, I told you that both epistaxis and telangiectasias are age dependent, and they develop over time. So while these Kurosawa criteria are still excellent for the diagnosis of HHT in adults, they do not work so well when applied to children. In fact, we were part of a collaboration a few years ago to evaluate these clinical criteria in pediatric patients. And we were able to demonstrate that the specificity shown in green is very good at any age. This means that if the criteria are present, it's highly predictive for HHT. But the sensitivity that you see here in blue is quite low in the youngest children. It improves with age and approaches that reported in adults by age 16 to 20. But this really means that the Kurosawa criteria are not the best way to diagnose HHT in children. Rather, genetic testing should be used to identify at-risk children who have HHT and need to undergo their screening for visceral AVMs. As you know, there are several genes that have been found to cause HHT. Endoglin and ACVRL1 make up the vast majority of cases, initially reported at 80 to 90%, but in one paper, again out of Utah, they actually found up to 96% of cases that were truly classic had a identifiable mutation in one of these 2 genes. About 10% of the remaining cases are caused by SMAD4, and then more recently, 2 other genes have been implicated in a few case reports, GDF2 and BMPR2. And this has changed kind of the way that we test over time through these HHT gene panels. Initially, we would test for endoglin and ACVR01, and over time added the SMAD4 gene. And as I talked about, the GDF2 and BMPR2 are much more recent. Most of these panels include RASA1 and EPHB4 as well. These two genes actually cause a related condition called capillary malformation arteriovenous malformation, or CMAVM. And there is significant overlap, particularly with EPHB4, because this has telangiectasias, nosebleeds, and even pulmonary AVMs, in addition to the known brain and spinal AVMs that can occur as part of a CMAVM syndrome. So when children are at risk for HHT, they have a parent with HHT and a 50% risk to inherit that, there are multiple time points that we can actually test the child. This can happen before a pregnancy, essentially doing in vitro fertilization and testing embryos prior to implantation. It can be done during pregnancy through chorionic villus sampling or amniocentesis, or it can be done after birth through cord blood testing at the time of delivery, or more traditional testing later on, but using blood, a buccal swab, or assisted saliva. And once that diagnosis is confirmed, or if a child can't be ruled out because there's no known mutation in that family, we recommend proceeding with screening, even in the absence of symptoms. And this is done according to the pediatric care guidelines. This is critically important because even when you can't see the outward signs, nosebleeds and telangiectasias, AVMs can already be there, and they need to be identified and treated if necessary before they cause symptoms. So here's a summary table of the pediatric recommendations that came out of the second International Guideline Conference. And you can see that there's variable quality of evidence, mostly due to lack of published studies in pediatrics, but there was a strong recommendation for each of these items shown here. So first, as we've already discussed, genetic testing is recommended when a familial variant is known, because testing will allow some children to opt out due to negative testing and not require screening. And all of those children who test in who are positive for the familial mutation will undergo screening. The second recommendation is to screen for pulmonary AVMs in all kids who either tested positive or were not able to be ruled out. And this is recommended to be done at the time of diagnosis. Screening can be performed in a couple of ways. There was some disagreement among the experts at this conference, mostly due to geography. In North America, almost all of the COEs use contrast echo or bubble echo for screening because it is safe and sensitive. But in Europe, most people follow the Dutch protocol, which uses pulse ox plus chest X-ray. And note that this is not just pulse ox. Pulse ox has a lot of weaknesses itself. And chest X-ray makes sure that we don't miss any large AVMs, because we know that kids can compensate so well, unlike adults, that they can actually have normal SATs even with a very large AVM. And a couple of other things to note, that when the Dutch follow this protocol, they consider anything under 97 to be abnormal. So this means 96 is not okay and requires additional workup, including a bubble echo. And all patients receive antibiotic prophylaxis for dirty procedures like dental cleaning, because they know they're missing their small pulmonary AVMs. So in North America, again, we just use bubble echo, and because it's sensitive, not everybody has to get antibiotic prophylaxis if they are truly negative. Number 3 recommends that large pulmonary AVMs or pulmonary AVMs that are causing low saturation be treated. And we recommend that even if the screening is negative, that we would repeat it again every 5 years. If it's borderline, it should be repeated earlier. And then number 5 is about brain vascular malformations. We recommend that all children at the time of diagnosis should have screening, which is an MRI. And if a high-risk brain vascular malformation is identified, such as an AVM or an AVF, these should be treated. And so my quick summary of our 6 pediatric recommendations is genetic testing is good because some kids will rule out. You should screen for pulmonary AVMs at the time of diagnosis. You should treat the ones that are large or symptomatic. You should rescreen those regularly. And you should screen for brain AVMs at the time of diagnosis and treat the ones that are high risk. These are actually quite similar to the adult recommendations if you look at it. Brain vascular malformations should be screened by an MRI, usually with contrast and with sequences to detect blood products. Lung AVMs, bubble echo is the clear first choice in adults. No liver screening is recommended for children. And anemia screening should be performed in kids if they have significant bleeding, nosebleeds, or any signs or symptoms of anemia. One other way to make sure that babies are safe and get a good start is to be sure that their mothers who have HHT are being well cared for. And for this reason, the second international guidelines also came up with pregnancy guidelines. And as we discussed, the first thing is we recommend that genetic testing be offered. This can be pre-implantation, preconception discussion, so that families know what they're getting into and what their risks are. Second, that any women who have symptoms concerning for brain AVMs actually have an MRI. This has to be a non-contrast MRI because MRI contrast is contraindicated during pregnancy. Recommended that women who have not been screened for lung AVMs or who haven't been screened for a long time should be screened. If they're asymptomatic, this can be a bubble echo. But if they're already symptomatic, we go straight to a low dose non-contrast CT. And if there's something that needs to be treated, we try to time that in the second trimester. Next, if there are untreated AVMs or the women have not been recently screened, they should have a higher level of care, as in high-risk OB or a maternal fetal medicine specialist. One of the recommendations was specifically that it's okay to use an epidural and that spinal screening for AVMs is not required. This has one that we have personally had some difficulty with our OB colleagues, or actually anesthesia colleagues. And finally, if there's a low-risk brain vascular malformation in the mother, she can still be allowed to labor, but may need some assistance on a case-by-case basis. So my whole overview for this is to say that when we're talking about children who are at risk due to having a parent with HHT, all of these kids have a family history in that parent. They may not yet show any of the outward signs such as nosebleeds or telangiectasias, but the visceral AVMs can be there in the brain and lung, and so screening is very important to keep them safe. And with that, I'd like to thank Cure HHT and all of the experts who participated in this consensus conference in Toronto in 2019, and especially our pediatric guidelines group, who are really enthusiastic and share my passion for taking really good care of kids. And then our center, where I really enjoy taking care of people of all ages who have HHT. And I look forward to answering any of your questions after Dr. Whitehead finishes his presentation.
So I have no disclosures for this talk. The other end of the spectrum, I think HHT is this condition where we form abnormal vascular connections, these arteriovenous malformations or smaller telangiectasia that have various clinical consequences. And some of these are likely to be present at birth, and some of them develop as we age. And really that, if we were talking about the visceral involvement, the brain and the lung are more likely to give us problems even in children, whereas liver tends to acquire problems with aging. The liver is a big organ and it has a complicated blood supply. It's really a prime target for HHT issues. It gets blood supply from two different sources. We have in the red blood coming from the heart through the hepatic artery, bringing oxygen and some nutrients to the liver. The liver also receives blood from the gut. All of the blood draining from the gut with nutrients and toxins comes to the liver for processing. And these two sets of vessels have to coordinate and deliver blood through the liver, where it then gets collected by the hepatic veins that take it back to the heart. So there can be abnormal connections between any combination of these three different sets of blood vessels. If the hepatic artery with high pressure connects to the hepatic vein back to the heart, you end up getting extra flow going through the liver, and that puts stress on the heart and can lead to high output heart failure and pulmonary hypertension. If you get connections from that high output or high pressure hepatic artery to the portal vein, it will build up pressure in the veins coming back from the gut, this portal hypertension. It can impair blood flow to the bile ducts and lead to biliary ischemia and scarring, and it can look like and mimic cirrhosis. If you get connections from the portal veins coming from the gut directly to the hepatic vein, bypassing the liver, then toxins can bypass the liver and avoid being cleansed and start circulating systemically, where they can impact brain function and lead to hepatic encephalopathy, a confusional or even comatose state from excess gut toxins that are not cleaned up by the liver. So what happens when you have a large shunt in an abdominal organ that over time starts demanding more and more blood flow? A scenario where potentially the work of the heart is increased by 50%. At that point, everything you do takes a bigger toll. Walking feels like jogging. Jogging would feel like running. Trying to run anywhere would be almost impossible. In that state, because of this high flow, you start to retain fluid everywhere throughout the body. Ankles get swollen, you get short of breath. This is a scenario that happens very, very commonly. Probably a large proportion of our audience has experienced it. Because pregnancy is exactly this state. The placenta behaves like a high flow shunting organ, like an AVM. Pregnancy mimics a lot of the effects of high output heart failure, but we tolerate it well because there's a defined endpoint. But imagine if the liver behaved like the placenta and there was no escaping it. Towards the end of pregnancy, the heart is pumping 50% more blood than it does at rest. It recovers very quickly afterwards, but imagine being stuck in that 7, 8, 9 months pregnant state forever. That can really exact a toll on symptoms and on the heart's efficiency. So how common is this? Liver involvement in HHT, if you look with detailed imaging, is quite common. 2/3 to 3/4 of adults with HHT have some evidence of vascular malformations in the liver, but fortunately, even amongst those, symptoms are rare. It's usually quite well tolerated. What we fear mostly is this state of high output heart failure where these large shunts start demanding extra flow from the heart. What is the normal state? The body normally, average sized adult, will be requiring about 5 liters or 5,000 milliliters of blood for normal functions. The liver will ask for about 300 milliliters of that. It's a small proportion. With exercise, your heart should be able to increase what it does, and someone that's a younger adult that's relatively fit should be able to generate somewhere around 25 liters of blood flow that their muscles might ask for to support exercise. Or in other words, we can increase what our heart does by about 5-fold. If you had high output liver malformations, your liver might be asking for, we've seen in the range of 5 liters of blood, some more, some less, that have this symptomatic state. So now the body still requires its 5 liters, and your total amount is up to about 10 liters of blood flow just to exist. Now, that ability of the heart to increase to 25 liters means you can only have a 2.5-fold increase, or half the ability to support exercise. And at that point, you feel short of breath at a level of exercise that most people would think is not maximal. At this same guideline conference, we were able to agree upon 8 guidelines that refer to the management of these patients with liver malformations. And the first 2 here, first is that screening for liver vascular malformations should be offered to all adults with definite or suspected HHT. Now, by screening, we mean looking for evidence of liver vascular malformations in adults where there was no pre-specified suspicion that there would be any abnormalities, asymptomatic people. The second is that we should do diagnostic testing for liver vascular malformations in patients who are symptomatic or show signs of complicated liver malformations, including these conditions that we've just talked about. So in a patient where you already had reason to think they had heart failure or pulmonary hypertension or some problem with liver function, we should not just do screening. We should do actual more detailed testing to find out what's going on with their liver. But all patients should have some degree of search to see if they have complicated liver involvement. This was a little controversial, and there are different places around the world that study this in different ways, and it really would be based upon local expertise. Essentially, this can be boiled down to a symptom-based or an anatomy-based approach. My preference is for a symptom-based approach where we aggressively screen for the complications of liver involvement and try and find those people who should go on to more diagnostic testing. The echocardiogram, the very same echocardiogram that included the bubbles to screen for lung AVM, can be used to estimate the amount of blood the heart's pumping, or the cardiac index, and signs of buildup of pressure and pulmonary hypertension. Blood tests such as the B natriuretic peptide and other versions similar peptides, these are hormones that increase in the setting of heart failure and are useful screening tests. Looking for liver function testing, screening for toxins like ammonia that might increase, all point to individuals who might have more advanced liver involvement. Once we've identified those patients, we move on to this diagnostic testing. Diagnostic testing involves some sort of imaging to characterize the impact on the patient, and different centers will have expertise in different areas. There's a lot of promise and excitement about the use of MRI, which would allow for flow assessment in centers that take this on. A standard MRI protocol that you could get at any large medical center would allow you to look at the size of the arteries that feed the liver and evidence of shunting as the contrast is handled by the liver. But it is also possible at centers to assess how much blood is being drawn through those arteries that feed the liver and get measurements of that. And we found that as a useful diagnostic and monitoring tool. CT scanning also shows a lot of the abnormal flows and the size of these arteries and could be useful for following. Ultrasound is a lot more user dependent, and you would be less likely to ask a small community hospital to give you an ultrasound assessment. But in a HHT center that has focused on this, ultrasound can be a useful tool as well. The best results are going to come from a team that has seen a lot of HHT patients and knows what they're looking for, most likely at an HHT center. I would aggressively confirm what we've learned from an echocardiogram with the more gold standard test, a right heart catheterization, essentially a long IV line, but that at the tip of the catheter can measure pressures and flows and tell you exactly what's happening in the liver, or sorry, in the heart, because of the impact of the liver. Now, other centers might choose to screen for liver with an anatomy-based approach, and here's where the real value of ultrasound comes in. It involves no radiation. It's less expensive than CT or MRI testing. The downside, as I mentioned, is it really requires a lot of user experience, and centers that only do this occasionally will not be as accurate as centers that have done this a lot. And at places like Utah, where a lot of our patients travel quite a lot of distance to come here, we've found that less helpful. But be familiar with what your center is using. This is the kind of information you can get. This is a CT scan. This patient also had later on a liver MRI to assess flow rates. This is a patient with an endoglin mutation with some abnormal liver enzymes that later we found were due to fatty liver changes and not at all related to HHT. And as a result, this is quite a normal liver with contrast in arteries where it should be, not contrast showing up early in the tissue of the liver. And this liver was only asking for 281 milliliters of blood per minute from the hepatic artery, a really normal amount. This is the scan of a patient with extensive liver involvement. And you can see these areas that light up with contrast on this CT scan outside of vessels, large dilated vessels within the liver itself. You can even see contrast showing up very quickly in the veins because it's shooting through these shunts very fast. This is a patient with a very large hepatic artery. It measured about double the normal width, which would be about 4 times the area or 4 times the potential blood flow. And when we measured flow, this is a liver that's asking for over 6 liters of blood per minute on top of what the body's asking for. A patient with high output heart failure. This is the patient who needs our help. So what does that help involve? Third guideline is that management of patients with these complicated liver AVMs should be managed at an HHT center and co-managed with an HHT cardiologist or pulmonary hypertension specialty clinic. At many of our HHT centers, that is an all-in-one place where the center director is involved with pulmonary hypertension or cardiology in our case. But in other centers, the HHT is directed by someone who doesn't manage these patients, and there should be co-management. And the fourth guideline is that we should be estimating our prognosis from available evidence to try and find the patients who are at highest risk and who need closer monitoring. And that available evidence is increasing all the time as we learn more and more about these patients. Some of that, here's an example. We looked at 200 roughly consecutive adults coming through our center and screened them all with our various ways of assessing cardiac output and signs of heart failure. And those that had elevated hormone BNP, it was about a quarter of all adults showed signs of living with heart failure, and that increases with age. Over 70 years old, it was the majority of patients that had evidence of some degree of heart failure. Not all of this was high output heart failure, but most of these patients had liver involvement. The patients who had high output heart failure, they were much more likely to have the ACVRL1 gene mutation than the endoglin mutation. The number of patients with SMAD4 mutations was so small, we really don't know where they fall in the spectrum. But patients with high output heart failure in our group all had evidence of liver vascular malformations, and most of them, or many of them, had anemia and lower hemoglobins. What are our treatment options? We have historically had for a long time the possibility of liver transplant. It works, but it's hard to get. It's particularly difficult because these patients usually have livers that are doing liver things well. They're generating protein, their liver enzymes are good, they're not turning jaundiced, and they're going to be on a transplant waiting list next to patients with failing livers and cirrhosis. And how can you compare these? The heart failure driven by the liver on one patient versus someone who without a liver has a really poor prognosis. That's a problem that is incompletely solved. Fortunately, other options have come along, and bevacizumab, which was originally designed as a cancer drug, has shown a lot of promise and has been quite helpful in managing various complications of HHT, and especially liver involvement with high output heart failure. We're hopeful that other anti-angiogenic drugs might also be useful, but we have less evidence. The pazopanib trial that Riley mentioned at the beginning of the talk is one of these drugs that we would hope would have promise. And in the trial, there will be a proportion of patients who have heart failure and liver involvement, and we will be doing extra testing to see if there's some evidence that it's helpful. Another important point is that we should not use the same tools we use for liver or for lung on treating liver. We should not use embolization therapy to put coils or plugs into these arteries. Most of these connections are microscopic, and it's hard to isolate the problem flow from the essential flow that's keeping the liver functioning. And complications happen when people embolize these livers. So when should we treat? Well, that's a good question. We don't have all the answers. The best treatment options carry risks. We're not exactly sure which patients who might have a visible AVM but no current complications are eventually going to have complications. That might help us target people sooner. It's possible that earlier treatment might work better than waiting for complications to become established. So the more we could understand the biology of this, the safety of our medicines, we might be able to become more targeted and be more effective. These treatments come up in our guidelines. We recommend that patients with high output heart failure that are symptomatic, that have not responded to first-line treatments like diuretics and beta blockers, should be treated with IV bevacizumab. And maybe one day other drugs will join that list. So treatment is usually this medical therapy for most patients. It's supervised by the HHT team, which involves your HHT director and the pulmonary hypertension or cardiology groups. And we should follow up to make sure it's working. And we should have liver transplant as an option. And we may need to advocate to the transplant governing bodies to get appropriate credit for HHT complications. And our transplant teams need education. I'm not confident that we can have liver transplant available everywhere across the United States, but there are centers that are transplanting HHT patients. Here's an example of one of our patients, a 34-year-old male with an ACVRL1 mutation who had become short of breath and had a family history of pulmonary hypertension and was concerned that that was also happening here. And he did have high pulmonary pressures. His mean pulmonary pressure of 25 is higher than normal. But he had very high cardiac output that explained most of that. His lungs were facing a deluge of blood flow because of what his liver was asking for. And when he exercised, the pressure only increased. His MRI supported a lot of vascular malformations and an enlarged artery. And he received treatment with a course of bevacizumab that was given 6 doses at 2-week intervals, so over 3 months. And symptoms improved. His epistaxis, nose bleeding, improved, with going from 2 or more long-lasting gushing nosebleeds daily to now 3 or 4 weekly dripping nosebleeds, a real improvement in his symptoms and also an improvement in anemia. And his cardiac catheterization continued to show mildly elevated pulmonary pressure, but a dramatic decrease in his cardiac output, and his exercise capacity went back to a level it had not been for years. We've found that we need to keep giving bevacizumab in this patient every 4 weeks in any longer interval, and symptoms start to recur. But we're hopeful that a patient like this can have a long period of disease stability. This was studied by the French group, and this study published in 2012. This is our best evidence for bevacizumab. Patients with high output heart failure were treated with a similar course of bevacizumab, and their cardiac output was followed by echo. Each of these lines here represents one patient and what happened to their cardiac index over 3 months of treatment, and then 3 months more of observation after treatment. You can see that in general, the flows decreased, and on average here in these grouped study data, there was improvement that was sustained, although there were individuals that did not respond and would have needed additional help. So those patients that are not responding, guideline D6 is that these should be referred for consideration of liver transplantation. And that might be the non-responding heart failure patients, those with biliary ischemia or complicated portal hypertension, where bevacizumab may not work as well. Another point to consider is to avoid liver biopsy in a patient with proven or suspected HHT. You can imagine that a CT scan is done and a doctor sees these areas that light up with contrast. In most patients who don't have HHT, that looks like cancer, and these look like a spread of tumors that are lighting up with contrast. If you put a needle to try and get a piece of tissue out of this, you're instead going to be putting a needle into a blood vessel with high flow and high pressure and might have really serious bleeding and potentially even death. And the last guideline is to avoid hepatic artery embolization. As I mentioned, it's hard to put coils into a liver into these microscopic abnormal vessels without also blocking off the essential blood flow keeping your liver alive. Last point for this talk is sort of a turn of direction. As HHT patients age, they face the same sorts of risks that anyone without HHT faces. And it's important to manage the AVM complications well, but heart disease, cancer, lung disease, stroke, these are all the most common causes of death for those without HHT, and they're common within HHT. Unfortunately, diseases like heart disease and stroke are best treated with blood thinning treatment, which might complicate HHT management. The most common form of heart disease leading to death would be heart attacks or myocardial infarction, where an artery builds up a cholesterol blockage, which then is complicated by a blood clot that suddenly blocks off flow and leads to damage to the muscle. Our best treatments to block to get on top of and stop a heart attack involve blood thinners. Ideal treatment these days involves putting a catheter into the blockage with a deflated balloon and a collapsed stent, using the balloon to expand the stent, which stays behind and keeps the artery open. This would break through the cholesterol blockage and push aside a clot and restore blood flow to a vessel that was otherwise causing a heart attack. These are life-saving treatments. In the days before any treatment was possible, if you had a clot in an artery, a myocardial infarction, heart attack, your risk of dying over the next month was about 1 in 7. In the early days, adding in potent clot-busting drugs with aspirin saves lives, and the death rate in 1 month drops from 1 in 7 down to 1 in 12. Once stents became available, the death rate drops to 1 in 20. So if you are having one of these myocardial infarctions, a STEMI is the other term, you should probably receive these treatments, even if you're prone to bleeding. The success rate and the survival rate are so much better. We may need to give you iron or blood transfusions or pack your nose. It may be a fight to avoid bleeding, but we should, for most patients, fight through that. Another common condition that leads to blood thinning is atrial fibrillation. And this happens to a lot of people. About 10% of everyone over the age of 80 lives in atrial fibrillation all the time. And from age 60 on, it becomes increasingly common. It's more common in heart failure. We see a lot of it in HHT patients with heart failure and anemia. And it's a major cause of stroke. In atrial fibrillation, the atrium stops conducting blood efficiently, and there's a side pouch called the left atrial appendage where blood can sit and stagnate and form clots that break free and go and cause the strokes. The likelihood of having a stroke when you go into AFib relates mostly to the likelihood of forming the clot. And that is a little bit predictable. People who've had previous clots and strokes, as we age, we become more clot prone. And we feel like at age 65 and then at age 75, there are important increases in this risk. Those with heart failure, high blood pressure, diabetes, vascular diseases like coronary artery disease, and women are all more likely to be clot prone and have a higher risk of stroke. We know that potent blood thinners like warfarin or apixaban and rivaroxaban decrease the stroke rate by about 2/3. Aspirin is not as good. It only prevents about 1/3 of these strokes. So when you take all of these risk factors and add them up, you can come up with a score, and an increasing score leads to an increasing yearly risk of stroke. Everyone with HHT who has atrial fibrillation will have their own threshold for when am I living with enough stroke risk that with my personal bleeding history, is it worth going on a potent blood thinner? We don't feel that any patient with HHT should feel like there's an absolute rule that they're not allowed blood thinners, but they certainly complicate management. So every patient will come up with their own idea of when they should be treated. That obviously brings with it an important need to monitor for anemia even more closely. But are there other options? This left atrial appendage is an anatomic problem that leads to clotting and stroke. Maybe there's an approach that would help that. And there are different ways where you can block off that left atrial appendage and decrease your stroke risk. The Watchman device is a metal and cloth plug that you can insert with a catheter into this appendage that would block it off. The problem is that we've now left metal and cloth in contact with the blood that's going straight past the brain. So for a period of somewhere between 6 and 12 weeks, everyone who gets one of these devices needs to be on aspirin and another potent blood thinner like warfarin or clopidogrel to decrease the risk that the device itself would cause a stroke. And then after 6 or 12 weeks, when you can confirm that it's in the right position and it's doing the right job, you can stop everything except for baby aspirin, and then you get the stroke protection of potent blood thinners with just aspirin alone. Most HHT patients that I've discussed this with are concerned about that lifelong commitment to being on baby aspirin, and I understand that. Another option is a surgical approach, kind of a minimally invasive surgery with a device like this that can put almost a clothespin-like clamp on the outside of that appendage and block it off from the outside so that there's no cloth or metal exposed to your bloodstream and no need for a blood thinner either the day it goes in or subsequently, and have that Coumadin level protection. Unfortunately, it does involve needing to go through a minor surgery, an incision between the ribs, and a hospital stay of several days to recover from that. In our patients that have had this surgical AtriClip done, we have been fortunate that we have seen no evidence of stroke subsequent to that, with an increasing number of patients that is giving us some confidence that it's effective. So as other diseases of aging, such as atrial fibrillation and coronary artery disease start to appear, it's important to have an HHT Center of Excellence help you manage this with your other doctors and balance your risks and benefits with what's known about your HHT. And we may need to adapt how we manage your HHT to help you cope with these other issues. I'd like to thank everyone at our center and those involved with the guideline process for the liver for this. And I will end my portion of the show and we'll go over to the Q&A.
Awesome. Thank you so much, Dr. Whitehead, for the thorough presentation. I'd invite all of our speakers to turn your cameras on and unmute yourself. And to the community, this is your chance. Go ahead and ask your questions. I know some holiday gatherings are probably taking place over the next few days. And with the genetic disease, you can pass along some of your newfound knowledge to your family members as well. So please do take advantage of this time to ask some questions. We do have a handful of pre-submitted questions with just a few minutes remaining, so we'll get to as many as we can. Let's take a look at the list here. The first question, I think I'll pass to you, Dr. Hammill, and you definitely addressed this very beautifully in your presentation, but it's important enough to bear repeating. But we had a question saying, hey, I have 2 children, ages 7 and 2. They're not showing any symptoms. When is most appropriate to get them screened?
Now, as soon as you can get to a center, ideally. But you can take those guidelines somewhere else if you can't reach a center, although I think Cure HHT can be helpful in directing you to your closest or even helping you make those arrangements if it's difficult.
Short and sweet, but perfect as well. Next question here. Dr. Whitehead, I might pose this one to you, but it's a question more broadly about HHT in aging. Does HHT, the disease itself, get worse as you age? Do things like epistaxis and nosebleeds get worse with age?
Different features of HHT do seem to increase with age. And in general, the small vessel problems, epistaxis, GI bleeding, and liver tend to increase with age. If you actually count telangiectasia on the skin or in the lips, they increase with age as well. They don't often have a lot of clinical consequences. Brain AVM, lung AVM, we have seen examples where there's been progression with aging, but they're much more likely to be present in children.
Thank you for that. My next question here is about frequency of screening, and I might pose this to you both, or you can both jump in here, but how often should things like the lung and the brain be screened and monitored in HHT patients?
I'll talk about the children aspect for now. I think there was agreement or suggestion in the initial clinical guidelines that even when it's negative, we would look at least every 5 years. More often if it's borderline or there's some small shunt that we're following. There's no exact time to how often you'd look. There's data that says that it can go from basically unmeasurable to treatable in 5 years. And so that's a reason to look again. And as far as brain AVMs, there was no agreement on that. We had a little bit of a struggle to get everyone to agree that we had to do it once. I think most in practice in North America, I think everyone does that initial one and at least one more at puberty when people are full grown. A lot of people do at least one in the middle when kids are old enough to get an MRI without sedation around 10 or 11. And some centers even do more often, like every 5 years. So there's a big range, but it's clear, I think, among people here in North America that we do at least 2 in a lifetime.
I would echo that. I think at a minimum, every patient with HHT should have a comprehensive look every 5 years. And that would involve some combination of screening for lung, complicated liver, anemia, iron deficiency, and make sure that the brain screening was done appropriately and doesn't need to be reevaluated. When we start to see more complications, when people are when bleeding becomes worse, when anemia has a higher risk, honestly, when you're starting to be suspicious that there might be a demand on the heart or that the liver is involved, it may be worth seeing patients annually, if not even more often.
Excellent. Thank you both for that. Looks like we have a question here live from John, an HHT patient who says he has lung and liver involvement. He's asking how much will regular exercise potentially decrease some of his risks associated with these AVMs?
It's hard to find any reason that we would tell someone not to exercise. I think that exercise, at a minimum, it gives you an idea of what your disease is doing to you and what you've got, what capacity you have left. I think that there would be reason to think that with heart failure of any sort, that getting regular exercise helps you maintain a healthy weight, which on its own decreases stress on your heart, and it probably improves efficiency of some of your blood flow to your muscles and would be helpful. But it's unlikely to overcome the source problem.
Excellent. My next one, again, might pose to you both. Feel free to jump in if you have thoughts. But the question essentially is, hey, I meet the Kurosawa criteria. I've been diagnosed clinically. Why would I need to be genetically diagnosed or tested then?
I would say for the rest of your family members, especially the young ones who might not have all of those yet, we need to make that diagnosis in a family member who meets criteria or who clearly has HHT to know what we're testing in their children for the yes or no answer. And then there are some subtle phenotypic differences that may be worth knowing about.
I think that every patient needs to know what their mutation is, but they don't necessarily need the blood test or saliva test themselves. If a family member already knows what the mutation is, you know what mother had, and now you meet the diagnostic criteria, it's safe to assume that that is also your mutation. And then when you are having children and you're screening them genetically, you would know what test to use to screen them for.
Perfect. One more question from the audience here, which is about TXA. I'm sure it's something a lot of community members are on, but the question is, I'm taking 6 tablets a day. Does this increase my risk of heart problems at all?
So tranexamic acid, the North American strength is a little different than the European strength, but 6 tablets a day, 650 milligrams standard tablet is the dose that's recommended for its FDA indication, which is for heavy menstrual bleeding. A couple of small studies in Europe used the European dose, which is 1,000 milligrams 3 times a day, slightly less, in HHT patients that likely were asked if they had had any previous clotting problems, because tranexamic acid, the risk is it would make you more efficient at clotting. So if you didn't have a pre-existing clot history and you were put on this drug in those European studies, they did not see any increased clotting or heart complications from it. But if you knew that you had coronary artery disease, it probably is not a safe drug to take.
Thank you for that, Dr. Whitehead. We are up at time here. We really appreciate both of your time and the thorough and helpful presentations. But before we depart, I do want to turn it over to each of you to say if you have any last message to the HHT community. It can be words of hope, any advice, questions you feel you're answering frequently at clinic that would be helpful for our audience here tonight to hear.
I would say that having cared for HHT patients at our center since 2010 and done a lot of pedigrees and heard the family histories, seeing all of the treatments that we have and seeing how effective they are, I think that the outlook for this generation is dramatically different than their parents. And given the pace of acceleration, I expect that the next generation will be even closer to that hoped for cure.
I would echo that. I think that's amazing. There are a lot of, one of the things that's changed is that companies are more interested in the disease. Cure HHT has really raised the level of visibility. And so there are a lot of companies who are interested in trying to help us all in getting to where we're trying to go. And so I agree. I think there are a lot of things that are coming for the kids now. So hopefully they won't have to go through all of the things that their parents did.
Absolutely. Great messages here to end our session tonight on. Before we depart, on behalf of everyone here at Cure HHT, I want to thank all of you for attending tonight's webinar and for staying connected with us. Again, I want to thank you both, Drs. Hammill and Dr. Whitehead, for your time tonight. This program has been recorded again as a reminder and will be posted on our website. We do appreciate your participation, and please do remember to fill out that survey that will be sent to you after tonight's webinar. We hope everyone has enjoyed tonight's programming and have a good evening. Take care, everybody.